everyone. My name is Dr. Renu Joshi. I am an OB-GYN by profession as well as a robotic surgeon. I own my own private practice called Joshi Women Care, and I also lead a physician organization called SAPNA, South Asian Women Physicians of North America, along with Dr. Sonal Bagor, and we have our esteemed moderators that help us along, managing the whole group. Dr. Sudha Yalamanchi is one of them, and she's here today. I have the privilege of introducing Dr. Lukena Karkhanis to all of you. She is extremely famous all over the country in the field of allergy and immunology. Dr. Karkhanis has written multiple papers and has done a lot of research in this field. She's double boarded. She is internal medicine as well as boarded in allergy and immunology, as I said. Currently, she is working with Allergy, Asthma, and Immunology Associates of South Texas. Dr. Karkhanis she gives interviews in multiple news channels regarding her subject, and she has graciously agreed to talk to us about COVID vaccine updates. I'm sure all of us have a ton of questions regarding this infection, and she had already given us a talk in the past about the COVID vaccines when they had come out in the open, and now that we are a few months into the vaccination process, we have new COVID variants that are out. We have reinfections coming in, and of course the latest is the booster vaccines that are out in the market, and we all have several questions regarding the same. So she's going to give us a little talk about it, and then we can ask her some of the questions. Like, I have questions that some physicians asked, as well as some questions that were asked by non-physicians. So without much further ado, and without taking too much time, I'm going to hand the baton over to Dr. Karkhanis. Thank you so much for being here today.
Hi, it's great to be here. Thank you for the opportunity to Savapna and to Renu. This is a quick talk on just an update on the new variants, because there's been a lot of interest on how they've affected the vaccines, how the vaccines have affected them, and then we can have a Q&A session. So quickly, the numbers for COVID-19 keep going up. So as of August 20th, there have been more than 200 million cases worldwide, out of which almost 40 million are in the US alone, with almost 4.5 million COVID-19 deaths worldwide, and over 600,000 of those are in the US alone, attributed to just COVID-19. So the pandemic is definitely still very much in force, and the numbers, as expected, keep going up. This is a quick view of where we stand in the United States. This is from August 9th, and this shows us the states, it's split up into yellow, which is a threshold of about less than 10 daily new cases per 100,000 population, orange, which is less than 25, and red, which is more than 25. And most of us are in the red and the orange, very few in the yellow, and very, very few, none in the continental United States are in the green. So cases have definitely seen an upswing as of mid-July and early August. And this is a look at the ICU beds, because that is one thing that all of us as doctors always look at. How many ICU beds does our region have left? This is as of, again, the first week of August. You can see the number of ICU beds, and you have the non-COVID ICU beds, then you have the COVID ICU beds, and then you have unoccupied ICU beds. And you can see the clear trend where we had that huge upswing in COVID in January and February. Then it went down considerably in May, and then in July it started going up again. And now as of August, we have more and more ICU beds going to COVID. We have lots of states and counties shutting down non-emergent procedures, surgeries, admissions, purely because there is a staffing issue with COVID. So what are variants of concern, right? So like any living organism, viruses mutate, and COVID-19 mutates. And every time there is a significant enough mutation to be given a new classification, there are several ways to classify them. There is a Pango lineage, which uses a software called Pangolin, and that's why it's called Pango. There is a GISAID, CLADE, and that's GISAID stands for Global Initiative for Sharing All Influenza Data, but now of course they're sharing COVID as well. And then there is a next strain clade. So virologists worldwide use kind of different classification systems. And to make it simple, WHO has said, let's start from alpha, let's go from A to Z like we do for hurricanes and things like that. So we started with alpha. So we had the original COVID strain that came out of Wuhan, and then the first variant that came out was called alpha, and then beta, gamma, delta, so on and so forth. When a variant is thought to have potential to increase transmissibility and possibly affect public health measures, it's called a variant of interest. And then when it actually affects transmissibility, public health measures, and local health supplies, that's when it's called a variant of concern. So not all variants are variants of interest or variants of concern. It just depends on how lucky the virus gets and how they spread. And so the main one of interest right now, worldwide and in the United States, is the Delta variant. And you can see from the slide, it showed up in India in about October 2020. It was just an unfortunate kind of perfect storm there with a loss of social distancing measures, lots of population that lives in, multi-generational households where they can't really socially distance. And so every million mutations, if the virus gets lucky and gets a good mutation, the more people you have getting infected, unvaccinated, the more mutations you'll have, the more chances the virus will have of getting a really good mutation. So that's how these variants come about. And so Delta started in India in October 2020. And in April, it was considered a variant of interest because people realized it's highly transmissible. And then in May, it kind of started overwhelming the system in India, and it became a variant of concern. And now in July and August, it has become a variant of concern in the United States. Most of the mutations that are being monitored are in the spike protein, because that's the protein that the virus uses to infect essentially, and that's the target that all our vaccines have chosen. So those are the mutations that virologists are kind of monitoring very, very closely. So this is Delta variant spread, again, as of early August. And this is from all sequences that have been submitted to that GSAID organization in about 4 weeks. So last week of July or first week of August, maybe last 2 weeks of July, first week of August or so. And you can see how many of the submitted samples are now Delta. So United States, 80% of the submitted samples are Delta. Mexico, 80%. Most of, you have Russia, 80%. India has dropped down to about in the 60s or so because the Delta kind of burned through there in April and May. And a lot of the other countries are in the 20 to 40% range. And then a lot of countries, they don't submit data. So we don't have data on them. But as you can see, in countries where sequences are being monitored, Delta is very, very high still as of July and August. And if you want to look at numbers, if you look at the Delta variant cases, right, US is leading. India is not in here. I think there has been kind of a breakdown in the workflow to get enough samples sequenced from there. There has been a lot of concern with the fact that the private labs, they really can't sequence or not allowed to sequence. And the government labs may not have the capacity, may not be able to sequence it quickly enough. By the time the sample gets there and gets sequenced, it's already too late to be of any practical use. So just in 4 weeks, UK had almost 60,000 Delta cases, US had about 16,000. And then cumulatively, UK is leading because they are the ones who submitted a lot of samples, over 200,000 Delta cases. So what does the Delta variant really do? Why is it a variant of concern? It's thought to be twice as contagious, so 40 to 60% more likely to spread compared to Alpha. And then significantly more viral particles have been found in the airways of patients infected with Delta variant. So not only does it spread more easily, but it looks like it just multiplies a lot and you have more virions, more infectious particles, basically. It's causing more severe illness in unvaccinated persons right now. And the greatest risk of transmission is among unvaccinated people, because here you have something that just multiplies very rapidly, spreads very rapidly. And if you have unvaccinated people who have no protection, this is like a golden opportunity for the virus. Vaccinated people, though compared to Alpha, if the same vaccinated person was exposed to Delta, then yes, Delta will still be more contagious and still have more viral particles. But you have to remember, compared to unvaccinated people, vaccinated people, even with a Delta infection, are infectious for a shorter period of time. They tend to become infected less. They tend to have less severe illness. So the vaccine will protect you. It will keep you from catching the infection. And if you catch it, it will keep you from spreading it, and it will keep you from getting severely sick. So those are the three main things. It prevents infection, reduces spread, and it reduces severe illness, hospitalizations, and deaths, basically. With the Delta variant spread, hospitalizations have skewed younger, and some think that it is because the older population, there were higher vaccination rates than younger, and below the age of 12, nobody is vaccinated in the United States. Symptoms are not necessarily more severe, but fever, headache, sore throat, and runny nose are more common. Cough and loss of smell are not, but again, this is not absolute. This is just kind of observational data at this point, because it's still COVID-19 infection. So essentially any URI-like symptoms could be COVID-19 today, just as they could have been COVID-19 last year. And then more children are falling ill because more are being infected. So given the current scenario in the United States, we've all had to send our children back to school in person. Most of the less than 12 are not eligible to get vaccinated. And it's like we're conducting a mass experiment to see what is going to happen. And you can see that the virus will spread, because when you have large amounts of unvaccinated people together in a closed indoor setting, then the virus will spread. And if you have the Delta variant, it will spread more easily. So more children are falling ill because more are being infected, not necessarily because the Delta is worse for children. And this is a slide that I actually keep a screenshot on my phone to kind of show patients if I'm ever trying to talk to them about why they should get vaccinated. And these are national estimates. If you look state-wise, certain states actually have even more stark of a difference. So you can see that there is a way higher risk of getting COVID-19. The blue bars are your vaccinated people and the green bars are unvaccinated. So there's at least an 8-fold reduction in infection, just COVID-19 infection, if you're vaccinated versus unvaccinated, and at least a 25-fold reduction in hospitalization and death. And in some states, this is turning out to be like 100-fold reduction. You are more than 100 times more likely to be hospitalized with COVID if you're unvaccinated. So very stark differences being seen here. Definitely the vaccine protects. So the Delta variant, just because it's a new variant does not mean that the vaccine does not work. It does work, maybe not as perfectly as one would hope, but still very, very well. And so what has the vaccine effect been? So as of July 22nd, nationally, 97% of patients hospitalized with COVID-19 are unvaccinated. And the 3% that are vaccinated are probably immunocompromised or have multiple comorbidities. And of course, there are going to be some that get unlucky, get vaccination, do everything right, but still fall really sick. But 97% are unvaccinated. And the study which looked at the Pfizer vaccine, so an mRNA vaccine, and then AstraZeneca, so adenovirus vector vaccine out of Europe, they looked at vaccine effectiveness with the Delta compared to the Alpha, with 2 doses of Pfizer and 2 doses of AstraZeneca. And there were only modest differences in the efficacy of the vaccines with the Delta versus Alpha. So for Pfizer, the efficacy went from the 94% with Alpha to 88% with Delta. Still very, very good. You have to keep in mind our flu shot is about 50% effective. So 88% is still more than AstraZeneca is even with the Alpha. And then the AstraZeneca is thought to be about 74, 75% effective with Alpha. It dropped to about 67. So yes, that efficacy is a little less. The virus got smart, the virus got lucky, but it's still very good as compared to being unvaccinated. And as of July 22nd, there were about 65,000 breakthrough cases. So by breakthrough, we mean fully vaccinated and tested positive for COVID-19, not necessarily severe, just positive. So among the 160 million people vaccinated in the United States, 65,000 cases, which is about 0.04%. And in August, this has dropped down even more. We are overwhelmingly seeing unvaccinated people being the ones that test positive, get hospitalized, and die. So the vaccines are effective. They are effective enough to not have to worry that we may be it may be an overkill to take the vaccine. It is not. It's still a very good vaccine. Then there are some other COVID-19 variants of interest. These have not yet actually affected public health and transmissibility to become of concern. And the main one that a lot of people are paying attention to is the one called Lambda. So imagine we started with Alpha last year, we're already to Lambda. So once we reach Zeta, we have to start all over again. Lambda showed up in Peru in December of 2020, and that one is being watched very carefully because it's of concern in young children. As of now, it's not yet of concern in the United States or in Peru, it's just of interest, but that is the other one that people are noticing and paying attention to. So that might be the next worrisome thing once we get over the Delta bump. So what about the Lambda? It has a twofold increase in infectivity due to a particular mutation on the virus, the L452Q mutation. And according to GISAID, there are over 100 cases of Lambda in the US. So very few compared to the fact that we are testing hundreds of thousands positive every day, but we do have Lambda already in the US. But the mRNA vaccines are effective against the Lambda variant. So the Lambda variant, not yet a variant of concern, maybe it won't be. It will depend on largely our public health measures and what we are able to do with vaccination, masking, and things like that. So what prevention strategy do we need, right? This is kind of similar to what we always talk about on QI committees. Those of us who are on QI committees and we attend M&M conferences, you need a layered prevention strategy. It's a Swiss cheese model, so you put multiple layers between the error and the actual effect, hoping that if there's a hole at a particular point in one layer, another layer will cover it. You need masking, you need vaccination, and you need to stop getting together in large group indoors. And then the AAP, the American Academy of Pediatrics, strongly urges in-person learning, but it urges all who are eligible to be vaccinated to protect against COVID-19. Everyone older than age 2 has to wear masks, regardless of vaccination status, as much as possible. There are exceptions for special ed students and things like that. And then it does stress building ventilation, testing, quarantine, cleaning, and disinfection. Just a quick note, in case the Zoom session ends, I think we can just log back in, all of us, and it should bring up the same meeting again. Okay, and so what are the vaccination recommendations, right? So this is the summary document from the CDC, and these are the only official recommendations out there as of this time, and they may change in the very near future. So you have the Pfizer and Moderna mRNA vaccines, and then you have the Janssen or the Johnson & Johnson adenovirus vector. Pfizer is greater than or equal to 12 years. The other two are for 18 years and above. They have their own doses, 0.3 ml, 0.5 ml, 0.5 ml. Pfizer and Moderna are 2 doses. Johnson & Johnson is 1 dose. Interval between doses, 3 weeks for Pfizer, 1 month for Moderna, and Janssen is a 1-dose series. So these were the initial kind of recommendations. And then what about common questions? What about interchangeability, right? They are not considered interchangeable. However, you can interchange them if you can't take, if you have a contraindication to the second dose, or second dose is just not available, you can change them. Interchangeability may be allowed. So it's kind of up to the doctor's discretion. Biologically speaking, there's not any reason why you have to stick to one vaccine brand, right? All 3 of these vaccines essentially trigger a very temporary production of spike protein. That's all they do. And then the vaccine is gone, whether it's mRNA, adenovirus, whatever, it's destroyed in a few days. The spike protein hangs around for a few days, and then the protein is destroyed. And essentially what remains is your body's response, your B cells, T cells, and your memory cells. And so it should not matter what triggered that initial spike protein production. So interchangeability biologically should not be a problem. However, for currently they say, unless you have to, don't change. What about COVID-19 and other non-COVID vaccines? Now they're saying you can give them on the same day. You can give the vaccines on the same day. You don't have to wait initially because there was a lot of concern about side effects. They were saying space it out by 2 weeks, 4 weeks. Now they're saying just give it out on the same day. What about people with prior or current COVID infection? The vaccines are safe and you can give them once they are out of quarantine. So you don't have to wait for 3 months. You don't have to wait for any particular amount of time. Women aged less than 50, they can receive any 3, but you should inform them of the risk of that thrombocytopenic thrombotic syndrome after Johnson & Johnson. So if the other COVID-19 vaccines are easily available like they are everywhere in the United States, women less than 50 probably should take an mRNA vaccine. People who receive monoclonal antibodies or convalescent plasma for COVID-19 treatment, they recommend defer vaccination for about 90 days because there is some concern, theoretical, that the antibodies in the monoclonals or the plasma might neutralize some of the spike protein and you may not get the best chance at mounting a reaction. Persons with a known COVID exposure, you wait till the quarantine has ended basically. And if you're in a congregate setting like a nursing home, you don't have to wait. You can vaccinate them if they are asymptomatic, even if they've been exposed. Probably because if you wait, they're going to get really sick and then you lose the benefit. If you have a history of heparin-induced thrombocytopenia, then first 90 days prefer mRNA vaccine. After 90 days, the FDA says you can even take the Johnson & Johnson. These are very rare conditions, really. Persons with any underlying condition can receive the COVID-19 vaccine. Persons with immunocompromise can and should, in fact, receive the COVID-19 vaccine. If they're taking Johnson & Johnson right now, just take 1 dose. If they're taking mRNA, this is the new thing, then you take 2 doses and you take an additional dose. So if you're an immunocompromised person and you're starting your series now, you should just take 3 doses. So you take the first dose, the second dose, 3 or 4 weeks, and then another 4 weeks after, take a 3rd dose. So it's not even considered a booster. Immunocompromised people are just being asked to take 3 doses of the mRNA vaccine. If they've already taken 2 doses, go take the 3rd one. Guillain-Barré syndrome, you can take any of the 3 vaccines. However, if available, like they are in the United States, prefer mRNA vaccine. Breastfeeding, pregnant, trying to get pregnant, can receive any vaccine, but you do have the risk of TTS. So depending on availability, take the mRNA vaccine. But we do strongly recommend that women who are pregnant, breastfeeding, or planning to get pregnant, planning to breastfeed, do get the COVID-19 vaccine. It's exceedingly safe and it does help a lot. Adolescents 12 to 17 right now can only get the Pfizer-BioNTech. 18 and older can get any 3. If people are vaccinated outside the United States, so that's a big concern in a group like this where we have parents and family members that live outside, got another vaccine, and then came to the US, what do you do, right? If they've received an FDA authorized COVID-19 vaccine, obviously they just follow the same algorithm as all of us. If they received a non-FDA authorized vaccine, so in India you have Covishield, Covaxin, neither of these are FDA authorized. If it's a WHO listed authorized vaccine, so that's Covishield, you may be offered, you don't need any additional doses because the WHO authorized vaccines are considered okay. If it's listed for emergency use, but the patient has not finished all their recommendations, then you just start from scratch with one of the US authorized, FDA authorized series. And if it's Covaxin or any vaccine that's not listed for emergency use by WHO, then you offer them again to start from scratch with the FDA authorized COVID-19 vaccine. So essentially, if you got Covaxin, you have to restart and get Pfizer or Moderna or Johnson & Johnson. If you got Covishield, you don't need to. I know people who got Covishield but still chose to restart and get the FDA authorized series, and you just have to watch out for mild side effects every time you get any injection, but they haven't really suffered or anything like that. Contraindications, really only anaphylaxis to the first dose or any known component. So really nobody fits in this category. The NIH has now started a study to give even these people the second dose in a monitored setting with a crash cart, and they're giving it. And then if they have an immediate allergic sounding reaction, then you just send them to an allergist. And most of these patients that come to me, I've been able to get them the second dose. Precaution, as usual, if you have a history of reactions, then you should consider seeing an allergist. And again, all of these people, I've been able to give them the second dose. Post-vaccination observation period, at least 15 minutes for everybody, 30 minutes for those who have kind of a slightly higher risk because they have a history of anaphylaxis or a reaction to vaccine. And then antibody testing is not recommended to make any sort of vaccine decision. Not whether you should get the first dose or the second dose or the third dose or the booster dose. We do not recommend checking antibodies because we do not know how to interpret those antibody results. It could be positive, but who knows if that's a good enough titer and good enough quality of antibodies. It could be negative, but maybe you have great T-cell immunity. So it really doesn't help. So lots of people doing this, lots of labs doing this, very poor consistency and reliability for the results. And so antibody testing is not recommended.